Thank you, Paul. Yep, agreed. Okay, well, good morning, everybody. Thank, thank you all for attending this morning. Um, Apologies, I have one at the moment. Councillor Tracy Shepherd, who's being replaced by Councillor June Tandy. Are you with us, June?
Yes, I'm here, Chair.
Yeah, well, welcome, June. Are there any other apologies, Paul?
Thank you, Chair. Yes, an apology from Helen Atkins. She may be able to join us at some point during the meeting. And Councillor Penny O'Donnell, who's the new Stratford member, is having some internet difficulties this morning. She again hopes to join us at some point, but is struggling at the moment. Thank you, Chair.
Okay, fine. Thank you. Are there any disclosure of pecuniary or non-pecuniary interests at all? Joe, I see one.
If we touch on the Ellen Badger at any point, I'm a member of all sorts of things to do with the Ellen Badger Hospital in Shipston.
Okay,
so fine. I declare masses of interest.
Thank you. And Jerry, I think your usual.
Yeah, I'll be Director of Health Watch Warwickshire, especially as it's on the agenda as a main item.
Yeah, okay, fine. Could I just take the opportunity at this point to remind all members, if you will remain on mute, and if you wish to speak, indicate with the hand, and I will call you in. Also, regarding the presentations we have today, questions will be taken at the end of the presentation, and I will be looking at making sure anybody who wants to ask questions, I take note of who's put their hand up. Chair's announcement. Well, I was going to welcome Penny O'Donnell, who is replacing Chris Kettle for Stratford on Avon. And I would like just to have recorded my thanks to Chris, because he has been over a number of years a committed member of the committee, and I've always thought he's always given welcome comment and advice on the work of this committee. So I would like our thanks recorded and passed on to Joe. Perhaps you would be good enough to pass on our thanks to him.
I certainly will, and I'll add my own, because he's a very useful chap.
Thank you. This morning we do have David Eltonham representing George Heliot, and as chair of the Warwickshire North Place Executive, and I think with him Jenny Northcote, who works jointly across George Heliot and Coventry and Rugby CCG. Are they both with us?
Yes, good morning, Chair.
Thank you, David. Good morning to you. Thank you. Just to update members of the committee on discussions we had at the spokespersons meeting, we're going to put this an early item on agenda. What we're going to do is ask members to raise any questions we have to the NHS commissioners or service providers, raise them to Paul or myself, and we will collate them, and then we will ask the relevant attendants of commissioner or CCG or hospital, whatever, to answer questions. In that way, we can ensure that we get the right person at the time to speak to us to the committee. So that will be on the agenda for every committee. We've also had some discussions already forewarning the providers and commissioners that this is going to be taken, and we've had a good response so far. I've also I think you've all seen, we've sent letters to all our acute hospitals, and we've had responses from 3, which have been circulated to members. An item on the for the next meeting. Correct me, Paul. I think it's January, isn't it, or February?
It's in February, Chair.
February. Thank you. Our next meeting in February, we will be inviting the West Midlands representative from the West Midlands Ambulance Service to attend. So, all members, if you've got questions, please send them in, and we will make sure that we get the right people to attend the meeting, armed with the answers to our questions. I've mentioned David Eltringham. My intention is to allow him to give us an update, to include a response to the points that we have previously raised about phlebotomy, and include the letter that was sent on waiting time data. My intention is that we will deal with that immediately after the next item, which is minutes of previous meetings. Now that's all I have, so we'll go on to minutes of the last meeting, and which was 30th of September. Are you happy that they show a true record of the matters that were discussed and recorded at that meeting? If we could have a proposer and a seconder. Thank you, Joe. Anybody else? A seconder will do. Yes, thank you, Margaret. Thank you. Okay, thank you for that. Were there any matters arising that members wanted to raise out of those minutes? Okay, well, I'm going to go quickly on and now ask David Eltringham if he will give us his update. So, David, over to you.
Thank you, Councillor Redford. So I thought I'd start with just a bit of a general position in terms of where we are at the hospital as it stands from a COVID-19 perspective, and then perhaps just highlight a couple of headlines from the letter. But it sounds like the letter has been shared with members of the committee in its entirety, so I won't read through it from beginning to end. Just looking at the situation in the hospital this morning, we've seen a steady increase in the number of patients admitted with COVID-19 over the last week. And currently we have just over 30 patients who are COVID swab positive within the hospital. The majority of those patients are on general wards, but a small number are in ITU or high dependency care. That probably reflects the rises in the numbers of infections that we've seen in the community translating into hospital admissions. And sadly, we've also seen a number of deaths, with 6 patients sadly passing away over the course of the last week. And I think I would just take the opportunity to remind members of the committee of the importance of the public health messages that sit around the COVID situation, around hand washing, making sure that people are wearing face coverings, maintaining social distancing and sticking to the lockdown rules, because if communities are doing those things, the impact on the NHS over time will be reduced. And so those remain extremely important messages, and I take every opportunity that I have when speaking in public to mention those things, because they are so important. If I move then to just talk about recovery, the letter that I sent back to Councillor Redford shows the work that we've been doing to recover out of the first wave of COVID. And in particular, I know there were concerns around cancer services and delays to cancer treatments. And you can see in the letter that as we came out of the first wave of the COVID pandemic, we had 46 patients who were waiting quite a long time for cancer treatment, more than 104 days. We've worked hard to reduce that. And as it stands, we have only 2 patients who are waiting longer than that period of time. And those patients, one of them has elected to wait for their treatment because they're worried about coming into hospital during a COVID pandemic, and a second patient has rescheduled their appointments. So those are matters of individual choice. The standard for treatment of cancer from diagnosis to first treatment is 62 days. And coming out of the first wave of the pandemic, we did have 136 patients who'd waited longer than that 62 days. And we've worked hard again to get that number down. We now have 19 patients in that position, and each of those patients has a management plan. So they've either decided that they want to delay their treatment, or we've agreed a plan to get them into hospital to complete their treatment with them, and those dates will then follow. Cancer services are absolutely reliant on diagnostics. And I'm pleased to say that we've reinstated the vast majority of our diagnostic and screening services. So 90% of our diagnostic activity is being recovered, and we expect that to increase over time. We do have a shortage of MRI radiographers, which is unrelated to the COVID situation, and that's a hard to recruit to group of professional staff, and that's actually one of the problems that we're challenged with in terms of recovering some of our diagnostic services. So that's probably nothing to do with COVID, and it's important to be really clear about that. In terms of planned outpatient and elective work, we were set a target of returning to 100% of pre-COVID outpatient activity by September, and 90% of pre-COVID day case and elective activity by October 2020, and those were national standards that were set by Simon Stevens in his Phase 3 recovery instructions. And I'm pleased to say that at the end of October, both our outpatient and our activity and our day case and elective inpatient activity were at greater than 100% of pre-COVID levels. And a good reason for that is that we opened a new standalone 30-bedded surgical unit with its own operating theatre attached to it in mid-September. And that we've called the Captain Sir Tom Moore Surgical Unit. It has 2 wards within it. And that has allowed us to protect surgical work and isolate it from the rest of the hospital. It's given us an incredible advantage in terms of that recovery work against where we would have been if we hadn't made the decision to put those beds on the site. So that's a really positive thing for the communities that we serve. The one thing that is challenging us is there are a number of patients who are waiting longer than 52 weeks for their routine operations. The number at the peak of delay coming out of the first wave of COVID stood at over 1,200 patients waiting longer than a year for their treatment. As it stands, that number is now in the order of 900, and we have a recovery trajectory which takes us to that number becoming closer to 500 by the end of March. This is a problem across Coventry and Warwickshire. So the COVID outbreak, we pretty much stopped all of our planned elective work. We were only doing urgent and cancer work, and the consequence of that is that people have waited longer and longer and longer for their treatment. The waiting times have pushed out, and so we've got a lot of patients, a lot more than we would like, waiting longer than a year, and that's a real challenge for us in terms of being able to manage that through the winter. And then finally, just to draw attention to improvements in urgent care. So our A&E performance has always been a challenge for the organisation, but performance against the national 95% 4-hour standard has improved significantly. And it would be easy to say, well, attendance has dropped off and haven't recovered, but in terms of coming out of the COVID pandemic, Phase 1, Wave 1, We're now back to pretty much 90% of attendances coming to the hospital, and our emergency admission rate is greater than 100% of pre-COVID levels. So that tells us that the sicker patients are still coming, and that's where we often found that there were delays in emergency and urgent care pathways. Our performance has been consistently better than 90% against that standard, and so I would use that as evidence of progress. There's still work to do, but it is progress against, if you compare to the same period in the previous year, our performance was somewhere between 73 and 78%, so it's a dramatic improvement with still work to do. And then the final thing we thought would be useful to update upon is phlebotomy, and this is a cross-system issue. So Jenny is going to give a perspective on behalf of the whole system around where we are with the phlebotomy service. So Jenny, over to you.
Thank you. I have prepared some presentation slides which can either be circulated after the meeting or unless you want me to share them on screen and go through them now. How would you prefer?
Please share them as well if you can. Yes, please.
Okay, I'll see if I can make this work then, so just bear with me. Let's bring this across. Got to work out how to share my screen. Okay, can you see that on your screen?
Yes, we've got that up, Jenny. Yeah.
Okay, thank you. Right. Okay then, so what I'm trying to do with these slides is just give you some of the headlines against the information that I'm assuming would be of most interest. So in terms of the current service status for phlebotomy. So obviously the phlebotomy service has had to respond to the COVID impact and in particular thinking about how we're going to provide services safely and how that's going to be delivered. And that's including things like social distancing, etc., which I'll come on to more. The community clinic delivery model has been something that has been instigated during this period, and that's given the ability to take bloods across a longer period of time. And the new sites that have been identified are those that are listed on the screen, so Balkan, Cosil, and Leicester Road Stadium. Patient feedback has been that they've welcomed the community clinics and some positive feedback around that, but there has also been some concern for patients that feel that places that they used to go to has been displaced, so that's just to acknowledge that point. In terms of phlebotomy capacity, there's several factors that sort of influence the availability of capacity, and I've listed some of these on the on this slide. So the space requirements at George Eliot has been unavailable, partly due to initial restrictions in terms of visits to the site and trying to ensure the integrity of sort of community transmission, but also that particular area that was used previously by the phlebotomy site has been used by something called ED2, which is where we do the triage around our COVID pathways, and has been one of the reasons we've been really successful in terms of maintaining our green and blue pathways, and also relates to the performance that you've just heard in terms of ED. The capacity impact for pre-COVID has meant that there was a capacity pre-COVID, and then obviously some of the displacement for then having to get new sites up and running, and also reconfiguring where the delivery has had an impact in terms of capacity. Social distancing in terms of the ability to provide the same number of bloods within the same period of time because of the nature of that social distancing, PPE requirements, cleaning between patients, etc. So there's been some kind of challenges there. And then also the need to provide services for shielded patients as well, and particular vulnerable groups that can't perhaps be mixed. So there's been those considerations in terms of a change in service model that the providers had to respond to. The phlebotomy service, therefore, in the context of all of that, has moved to an appointment-only service for those sorts of reasons, and has also offered an online booking system. But there has also been ongoing telephone booking for those people that aren't able to access through online. There's also been provision made for clinically urgent. So that's not that urgent that maybe a patient would consider to be urgent, but clinically urgent identified by a clinician, both whether that's in the acute sector or in GP practices. And there is a provision for appointments to be provided for that clinically urgent. In terms of the phlebotomy weights, they do this does differ across sites, and I have asked for some further feedback in terms of what that is driving that differential, and you can see that in the middle column in terms of the available appointments, etc. And you can see in the comment box some of the things that are being done to address those weights to try and reduce that disparity across the sites. So there is a difference to be acknowledged in terms of that situation. The capacity requirements have been identified as something that needs a system response to and some additional funding, and there has been a resource request that's gone to Commentary and Healthcare Partnership, and that is, I believe, going to the next meeting, so that's imminent in terms of that discussion. And obviously we do understand the importance of blood tests because they support a myriad of other services, so obviously it's like seeing this in the context of broader service provision. So that's the information in terms of a status update, and I'm happy to take questions at the appropriate points, but I'm happy to share the slides.
Thank you very much, Jenny. Have you any comment you wish to make, David?
No, thank you, Councillor Redford. Quite content with that.
Thank you very much. Then I shall open it now to members for questions, and Keith, you have a question.
Thank you, Chair. I've actually got a couple questions.
Okay.
Jenny's slides are a bit small on the technology we've got, so it'd be great to share what's going on in Nuneaton. But the blood testing seems to be at least 2 weeks delay again in Nuneaton, and Bolkington's not particularly accessible for residents without their own transport. So I do hope we can do something about the Nuneaton situation. And one for the George Eliot. One of the issues we had at the end of wave 1 was getting quick swab tests back. You mentioned about 31 tested positive for swabs, but has the hospital got a quick turnaround still on swabs so that the people who have been admitted in the last 24 hours get put into the correct coloured pathways quickly and aren't sitting mixing with people who may be clean of COVID? So it's timescales of that. And the final one is, obviously we've had a big change in circumstances, and what during phase 1, wave 1, has anything happened in terms of maternity demand? Obviously, it's not 9 months yet since the beginning of the lockdown, but I've got no idea whether you're going to be swamped with people 9 months on from lockdown, or whether actually maternity is actually going to be quieter. But I didn't know whether maternity was actually sort of monitoring what's going on. Thank you, Chair.
Thank you, Keith. Jenny, David, do one of you want to respond?
Jenny, do you want to deal with the phlebotomy question, and I'll deal with the testing and maternity question?
Yeah, no, happy to. So the Bolkington site has been put in place to reduce demand on the Bedworth clinic, and there is public transport between the routes between Bedworth and Bolkington. The Nuneaton site, you are right, it's around 11 days. But they are looking to, sorry, you couldn't see the slides, but they are looking to add additional capacity at busier times, and they are sort of looking at how they actually do that in terms of the capacity, and that would be one of the priorities for any additional investment to bring those waiting times down, because it is a very busy site.
Thank you. So in terms of test turnaround times, so during the end of the first wave of the pandemic, we had access to equipment that was able to give us test results within 2 hours. Over time, the volumes of those tests has reduced as reagents have been in short supply. and our turnaround times have been in the order of 24 hours using the laboratory at UHCW. At times, equipment failures have meant those times have extended, but currently they are around 24 hours. There is new technology arriving on site as we speak and expecting to be operational in the week of the 30th of November that will reinstate the rapid turnaround testing capacity that we had and give us actually more than we originally had as we go into the winter. And we're taking this week delivery of something called a DNA nudge machine, which is one of the technologies that you may have read about in the press, which reinstates that rapid turnaround testing capacity. And in terms of maternity, we haven't yet seen any growth in demand, but we are keeping a close eye on the situation, because, as we are with all of our services, because we still don't fully understand what the impact of COVID has been on a range of things. Maternity is included within that, and we'll be happy to come back and brief further in a few months' time as that data becomes available and we've got a clearer picture of what's going on.
Thank you, David. June.
Thank you, thank you, Chair. Good morning, David. Just a question. Thank you for your report, and please give our thanks to all of your staff for the exceptional support and dedication they have shown over a very, very difficult time, one of the worst we've ever known.
Thank you.
Your report on cancer patients is extremely encouraging and welcome. One of the questions, though, that I am being asked, and this is certainly not a criticism of any way, but simply a question about the resumption of services such as ophthalmology or the hearing clinics. I know that they may seem minor issues compared to the big scheme of things, but people are starting to ask those questions. So, if I can give them a reply when they ask, it would be most welcome. Thank you.
So we are attempting to restart all of our services, and some of those services have been slower to get back to the position that we would want them to be than others. But ophthalmology, definitely something that we're very focused on. Audiology as well. We're actually looking to try and introduce some new service models that support people who are using this kind of service without having to bring them up to the hospital, and that's one of the reasons why it's taken us a little longer to move on some of this stuff. It would seem sensible with things like ophthalmology and audiology that we try and offer that service away from the main hospital site so that we're not unnecessarily bringing people up to hospital. And over the next few months you will see services begin to resume and pick up pace out in the community around those things. And again, I think it would probably be sensible in 2 or 3 months' time for us to come back and talk to those specific issues and give you some indication of the work that we've done to do things differently and to move some of those services into the community.
Thank you, David. Thank you.
Thank you. Pam.
Thank you, Chair. I've got a couple of questions for Jenny, please, about the phlebotomy. You're still, am I correct in saying you're still waiting 11 days for a result? Is that the average?
So on this, it is. So the information that I shared was the appointment time wait. So and it differs across the different sites. So there is quicker turnaround for appointment times than there are at some sites as opposed to others. In terms of the wait for results, I didn't include that within the information.
Sorry, that's my misunderstanding. So you're saying still people are on average having to wait 11 days to get an appointment?
No, I'm not saying on average. I'm saying that there's a difference between the different sites. So in Nuneaton, that is the current position at the moment. In other sites, it's different. But yes, in Nuneaton, that is the position on the Nuneaton site as it stands at the moment.
Right. Can I just ask you, what percentage of GP practices in the north run their own phlebotomy service?
I don't have the exact percentage, but we predominantly deliver through this contracted provision as opposed to directly through general practice at the moment in Warwickshire North.
Is that because the GPs won't take it on, or is it that you've chosen to do it that way?
I'm not entirely sure of the absolute history to this, but there is a commission service in this way to get the coverage, etc. Some individual practices do have trained staff to do phlebotomy. It's not a core part of the GMS requirement, so it would be an enhanced service or a different commissioned activity. And obviously, at the moment, we commission that through this provider contract as opposed to within individual practices. One of the reasons for that, I think probably historically, has been when the take-up would be differential in each practice, whereas obviously providing a service at scale means that you can try and target where some of the delivery sites are, and also have some equity of delivery or attempt to, notwithstanding that at the moment we've got some differences in time weights.
Yeah. A second question, if you don't mind. You said that you have procedures in place for shielding those that are shielding. Can you just give me an idea of what you're doing? Do you bring them into your clinics for the blood test, or are you visiting at home?
Okay, so just for clarity, on the commission, I'm responding from a commissioning perspective, so I'm not from the service provider directly. Right. So from the CCG, the commission.
David could answer that question.
But I can answer the question. So it's both. So there are some domiciliary visits for people that require that, and there's a specific sort of process and procedure for that, and that can be made by referral. And then there's also some protected clinics that are provided for people that are vulnerable, because as you'll be aware, when people are shielding, they can still attend appointments, but they have to be supported in terms of the environment in which they access these appointments. So, for example, there's specific time slots and specific venues that have been created to ensure that they can be safely seen, and that's also why we've got the booking system rather than it being walk-in, to manage some of that capacity and to ensure that we can differentiate those services.
Thank you.
Okay, thank you very much, Jenny. Les.
Yes, thank you, Chairman. Just for information, is that I've been meeting right through COVID and still am monthly or so with David, and also at the meetings our councillor Julie Jackson as leader of Nuneaton and Bedworth and the leader of North Warwickshire, and Inkling Bothers are also invited. And I just want to record my thanks to David for hosting those meetings and for the improvements that we've seen in the George Eliot for the benefit of the community, and add to the thanks that Councillor Tandy has added. We have come a long way forward, I believe, at George Eliot for the benefit of the community, and thank David and all his team for doing that.
Thank you very much. Thank you, Les, for that comment. I did have Margaret's hand up, but I think the builders have called on her attention, so perhaps she'll get back to us later. Now, I don't have any other hand up from members for questions. One last chance. No, okay. Well, David, Jenny, thank you both very much for coming along this morning and giving us an update. And certainly, we look forward to speaking to you in the new at a future meeting in the new year. So, thank you very much, and thank you and all your staff for the work that they're doing under difficult circumstances. It is very much appreciated. Thank you.
Thank you, Councillor Redford.
Item 2 is public speaking. Haven't had notification. Paul, anything?
Chair, no questions have been received for this meeting.
Okay. Going quickly on to item 3, which is questions to portfolio holders. And under this section, I have already asked Les to give us an update on the new laboratory facility proposed for Leamington Spa. So, Les?
Thank you, Chairman. I did have a briefing yesterday with Mark Ryder. So what I can say is up to date. I mean, all members of the county council who are on this committee have had briefings, but for others, and I'm sure we can share some of the original briefings through Paul if members want them, is that you will be aware that the government and that is the Department of Health and Social Security and the NHS together have sponsored two mega labs. The British one is for England is at Leamington Spa, and there's one going into Scotland. Work has started to get that up and running. For those that know the Tatchbrook Road in Leamington, it is in the larger of the two Wolseley Holdings Group buildings that are currently vacant. And that will be fitted out, and the fitting out will be in the similar way to the Nightingale hospitals, that it'll come in modular form so that it's a quick build so that work can commence. It will directly employ around 1,500 people to start, rising to 2,000, and probably 15 to 20% are high-level physicists and environmentalists and everything else, jobs that are needed, and some will be just doing the actual laboratory work and so on. And there is a current website out informing people of those jobs. So recruitment is effectively underway. And of course, we will have knock-on jobs from that in the supply chain to the laboratory, because this is not just for COVID. This is a long-term venture as part of the government's changing the way we deal with such outbreaks. So it'll deal with flu, cancer, all sorts of other diseases once the COVID work is bedded in and hopefully starts to cut back. So expecting to be open in early 21, which is next year. And it's a full, I say, long term, but it is about 220,000 square feet premises. So we're not talking about a small venture. We're talking about a big one. So that's the latest update. Work, I say, is commenced. Work also is going on between Mark Ryder is leading for the county, and Chris Elliott is leading for Warwick District. We are working together very closely on this to ensure we bring it to fruition. To secure what is a great forward venture for Warwickshire, but also so we get longevity of the outfit as set up, and also the long-term job prospects, which are very exciting for Warwickshire. So happy to give you that update, Chair. And for the members that are not Warwickshire County Council, I'll ask Paul to circulate some of the emails that we've had, because obviously the initial work was all totally embargoed. Council Second Command officers had to sign a legal embargo agreement. So this was if you like, in a way sprung on members and the public, but that was the way it had to be. So that's happy to take any comments, and if I can't answer them, Chairman, we'll record them and I'll take them back to Mark Ryder.
Thank you very much for that.
Then I have a couple of other comments I'll make, having dealt with this one, Chair.
Okay, Keith.
Thank you, Chair. It's absolutely brilliant having a new mega lab, but the problem is it can actually depress adding other capacity in the month before it. Yeah, if we're having ability to test hundreds of thousands of people put in from nothing, are we actually having any sort of bridging capacity added to our testing capacity just before the lab opens?
As far as I'm aware, Chair, there is no change to existing arrangements at all. And also, to go back to something David Elkin said, the local service at UHCW has been changed to ensure that all its work is Warwickshire based, to give us the capacity that David was talking about. So he's got his speed of turnaround back up. So as far as I'm aware, it's not going to affect the local capacity at all. And obviously they are talking to the medical sides of our universities as well.
Thank you, Les. Any other questions for Les? No? Okay, thank you very much.
Chair,
Les, have you anything else to add?
Just make one other point, as we've been talking about COVID and test and trace, just to make all members aware that all patients leaving our Warwickshire hospitals to come back into care homes or domiciliary care are having a full test 48 hours before they are released from hospital, so that we are 100% certain about the status of everyone leaving and coming into either a care home or social domiciliary care, but we also still have our blue bed capacity as well.
Thank you very much for that, Les. Anything further from members for Les? Okay, then we shall now go on to item 4, which is the Mental Health Health Watch Warwickshire survey, and that will be presented by Chris Bain. Are you with us, Chris?
I am indeed, Chair, and
Okay.
Thank you for the opportunity. Paul, can we get the presentation on the screen, please?
Yes, that's fine. Thank you. We've lined it up for you, Chris. And Deb Mosley is helping me today, and she will share her screen then. Just give us a second and we'll get that up and running for you, Chris.
Thank you. Just by way of introduction, we did send out the full report that Healthwatch has produced. And just for clarification, what we did not set out to do was to produce a critique of health and social care in Warwickshire during the pandemic. So I think members will see as we go through that actually the services provided come out pretty well from this. The purpose of this item is to promote discussion about some of the issues, to get food for thought, to look at communications to see if they can be tweaked to be a bit better, and perhaps to think about some of the assumptions we make about what people need. So this really was just intended to be an item that promotes thought. And what we are doing in Healthwatch Warwickshire is we are, whilst we don't have the capacity to do another survey on this scale again, what we are doing is looking very carefully at the people who contact us to see if the experiences are changing during this period of lockdown compared to the last period. And we're going to try and reach some conclusions about that over the next, it's a bit early to do so now, but we're going to try and reach some conclusions about that to see if things are shifting during this second period of lockdown. So with those words of introduction, the first slide indicates what we asked people. It was intended to be a timely survey. We ran it during May and July, during what I think was probably the height of the pandemic, to understand the impact on people. So about how they accessed information, what changes had been made to their services, and how they were feeling as a consequence of all of that. Can we go on to the next slide, please, Paul? Thank you. Now we had 1,107 responses in May, June, and just the first couple of days of July, really. We had 1,107 responses online and a further 15 by paper copy. What we didn't want to do was to exclude people who did not have access to the technology or were not comfortable using it. So we did send out a number of paper copies, and we were actually quite pleased to get some back, because by and large you don't do that. And within those numbers, and it's 1,122 in total, 187 people wanted to be contacted again about the outcomes of the survey, which for anybody who's done those sorts of surveys is actually quite a high number. So people were genuinely engaged in this process, and we were quite pleased with that. We were also pleased to note that the response rate from Warwickshire was higher than Coventry. And now I don't mean to be parochial, but I was really pleased about that. And we were in particular pleased about the responses from North Warwickshire, Nuneaton and Bedworth and Rugby, given it's historically been quite difficult for us to get feedback from those areas. So clearly the purpose of this survey was resonating with people, and we were pleased to see that. The bit that disappointed us a little bit was the black and minority ethnic communities did not respond in the numbers that we hoped they would. So we're trying to work with Equip and other organisations to see if we can improve that and overcome some of the challenges about getting responses from those communities. Those are efforts that we will continue to make. So can I move on to the next slide, please, Paul? Now this is about how people accessed information, and it was quite an interesting discussion we had with people. 18% of people told us it was difficult to keep up to date with changes in information. It wasn't that there was a shortage, it was actually quite hard to say which was the current information, because it seemed to change so quickly. And when I talk to people now, that still appears to be the case. It's not that they don't have enough, it's that they're having difficulty identifying which is the current information against what was the previous information. And I think that's quite an interesting one about messaging there. And anybody who's done data work will understand that control of which bits of information is actually one of the difficult things to do. So we number our data sources, 1, 2, 3, and 4, but members of the public by and large find that quite difficult. So we need to think about how we date those things, and about how we say at this point in time, this is what matters. And I think there's an interesting thing about messaging there. When we asked people about getting information about support in the community, 22% told us they found it difficult to access help for people who did not use the internet. And this is the whole issue about digital exclusion. And 17% said they found it difficult to know how to access local help for things like shopping and prescription. So there are issues there about how we contact people and the assumptions we make about contacting them digitally. And I think we need to think through those things quite carefully. Certainly we in Healthwatch are doing that and trying to think through what messaging we're giving people. And when I looked at how difficult people found it to get clear information and advice about changes to health services, 27% of people, 1 in 4, said they found it difficult to access information about changes to health services in particular, And within that, dentistry was a particular challenge for people. And in the early days of the pandemic, when I tried to find out information about what dental services were available, I found that quite difficult. So I wasn't surprised to hear about that. 14% of people said they found it difficult to get clear advice about how to manage physical health conditions, and 10% about how to manage existing mental health conditions. So I think we need to think through those things as well, just food for thought. And repeat prescriptions, 9% of people said they found it difficult to know how to set about getting information on repeat prescriptions. So can we move on to the next one, please, Paul? Communication needs came up repeatedly, and I think there is, the day that we get communication right will be a unique day in human history, because it's one of the hardest things to get right. 9% of respondents told us they had additional communication needs, and of those 9%, 48% of them said they would have liked information in a different way, including easy-to-read formats, which came out head and shoulders above anything else. 78% of people said they wanted it in easy-to-read formats, which is why we produced our report in an easy-read format. 22% they'd have liked it in braille, audio, or large print. And we're looking now at ways in which we can produce our briefings both in audio and by video. So it does seem to be a real issue for people. British Sign Language, 11% said they wanted it in British Sign Language. Now, one of the interesting things about British Sign Language is that I had assumed prior to doing this work that people who used British Sign Language could read English. And that is an incorrect assumption. And a number have said to me that their first language was British Sign Language, not English. So we need to think through about how we communicate with people who are deafened or have impaired hearing and who use British Sign Language. Only 4% said they wanted it in another language, but that might be because the response rate from those communities was lower than we would have wanted. There is a quote here from a resident, and I think it's probably worth looking at. The quote is, "My dad is blind. Written information is useless. He has had no information in a way that would have helped him. He is also over 80 but has been forgotten about. Without family support, he and my mum would have starved. The elderly were told to shield, but no one has checked on them." Now, I suspect, looking at other responses, that is probably an exceptional case. But it is something that we need to respond to in some way. Now, the next slide, please, Paul. And this is quite an interesting one about how people access healthcare that is non-COVID healthcare. And a lot of people were saying that actually their experience had improved during this, and they actually prefer these new ways of working. But there were some who said that they did not feel able to get their mental health and physical health issues resolved as they were not comfortable talking over the phone. Some people just prefer they get more assurance from a face-to-face discussion with a clinician. So they were saying there were no physical checks carried out by the consultant, so when the problem is discussed entirely on the phone, and people were not reassured by this. And this particular quote, "Although the words made sense, I think a physician will pick up other things about a patient by face-to-face consultation that otherwise go unseen on the phone." This is the issue about reassurance for people. So some people felt that was quite risky, and given the choice, they'd have preferred an actual person-to-person meeting in their current situation. And one of the repeating themes throughout all of this has been the anxiety of people in lockdown. And when we look at the phone calls we're getting now, that anxiety is still present. So even when the lockdown is eased, as we hope it will, particularly if the vaccine that is on the horizon comes to fruition, then I think some of that residual anxiety will still be there, and we need to think and address those, think about and address those things. So can I have the next slide, please, Paul? So 108 people told us about their experiences of healthcare for people with COVID-19 symptoms, and 64% rated their experience as good, which I was actually surprised about. I thought that was a really good result and a credit to everybody involved. So some of the people said we had a home visit from a doctor and paramedics organised via 111, excellent service. The test itself at the Ricoh Arena was very well managed. All services, NHS 111, emergency services, A&E and GP were all exceptional. There were some concerns about 111 and the ability to get through. But once that had happened, the service people got was generally described as excellent. Excellent advice and response from 111, paramedics, Warwick A&E and the GP. Can't fault the support we've had. Some concerns expressed about support from district nurses, but the doctors and nurses at the hospital were brilliant. My husband has been in ICU at Warwick Hospital and life support as he has COVID-19, and they have been brilliant. So by and large, people got through that pretty well, and the service they received was excellent. Can we go on to the next one, please, Paul? Again, some of the praise for services for maternity. There were anxiety, which is reflected in that, and some concerns about getting through on 111. But when people did get the service, it was generally described as excellent, and we can't fault the support we were given. So that was actually pretty good. I think we can all, some people can pat themselves on the back for that. Can I go on to the next one, please, Paul? I did mention about dentistry earlier, and that did come across as a problem. People felt that they were left in the dark and not knowing what services were operating, and suggestions like information could have been updated on websites. And there were also issues with medication, and people feeling that they were unable to get their medications, unable to get deliveries when shielding, and there were anxieties about medicines running out. And people appreciate the reason for virtual consultations, and some people saw it as more efficient and felt they were listened to better. So actually, the virtual consultations for some people worked better than face-to-face. But there were still underlying anxieties for some who did not feel comfortable using those means of communication. Moving on to the next one, please, Paul. Getting near the end now. The feedback on social care in terms of numbers was relatively small. We were a bit disappointed about that, and we're doing some work to follow up now. But people, by and large, said that some people said their care had stopped completely, and I suspect that was more a communication issue than anything else. The local authority, once alerted, were good. There were still some concerns at that stage about PPE. I think that's now been resolved. And patients with, or people with dementia having anxieties about changes in service, I suppose that was bound to happen. The stoma nurse was due to visit, but that was changed in a phone call, and the next call never happened. So there were some concerns and anxieties about social care, but on a relatively small response rate. So we're going to do some further work on that as we go along. So now the next slide, please, Paul. And this was the one that we probably had the greatest response on. Of the 1,122 people 839 of them responded specifically in respect to their mental health. 19% said there had been a great impact on their mental health. 55% said some impact, and only 1 in 4 said they felt there was no impact on their mental health. So we had 500, more than 500 individual pieces of information on how people felt their mental health had been impacted. Anxiety, depression, feelings of loss for the freedom we used to have. And that is still coming across, and people wanting to see a way out of the situation is still happening now. We're getting it on the phone calls that we've had. And people in a shielding category, living alone, no physical contact with anyone for 3 months, hard to cope with. Uncertainty about the future, missing social contact and the fulfillment of work, and people feeling a loss of purpose and no longer feeling useful is coming across now as well. And this is what I can thoroughly relate to: additional stress having to work from home with kids under the age of 4. And anybody who's tried to do that, well, they know what it's like. And the anxiety came through again and again and again, and I think there will be a residual anxiety. So the final slide, Paul, if we can just go on to that. So what we're doing now in response to this report, we've shared it, and this is part of that process. We've shared it with the wider public, and we continue to ask the questions that we asked at the beginning of the report of people who call us now. And we're continuing to accumulate both anecdotal and data-based information so that we can see how it's evolving and whether there are lessons to learn from a second wave. There are themes coming through about people feeling that they have been forgotten, about the communication, about information about when services will restart, and a concern over the lack of non-COVID related services. So those are the findings, Chair. Overall, the services seem to have come out pretty well. And people by and large feel that the service they've had when they get it is excellent, but there is always this underlying anxiety about what the future holds for people. And I think we need to look at the way in which we communicate with people and recognise those anxieties when we communicate.
Thank you very much, Chris. That was an excellent result on your surveys. We seem to be getting a bit of feedback from somewhere. Everybody make sure you're on mute. Chris, could I just ask one thing? From your survey, might be putting you on the spot a bit when it comes to Warwickshire County Council, but did you find anything specific to Warwickshire County Council that you felt there was a need to address? I'm being specific to the counties, you know. Partly because that's our role, of course.
Indeed.
As an overview and scrutiny committee.
Indeed. I think the one theme that shines through in all of this, and we're still getting it in the calls we're getting now, is the impact that loneliness and isolation is having on people.
Isolation, yeah.
And people feeling that they have been not quite forgotten, but they're feeling that it's the sense of loss for what they used to have. And the feeling now that they have been forgotten and they are no longer useful. And I do think there are ways in which we can think about how we can talk to those people, communicate with them. I have no doubt there's a role for the third sector in beginning to look at some of those responses and beginning to work with some of those people. And if we can begin to restore some sort of interaction with people, even if it's just through a window, people are saying that human contact is what really matters. And there is something about, we've had a number of concerns now about visiting to care homes and about particularly people in care homes who have dementia, who cannot fully understand why the previous visiting regimes are no longer applying, and see if we can think creatively about how we can deal with that. Because it is creating anxiety not just in the care home residents, but in their relatives who can no longer visit and are concerned about what's happening to their relative in that care home. And if we can start to do some of that, and that anxiety came through all the way through this survey, Chair.
Thank you very much for that, Chris. Now I've got a number of people who want to ask questions. Kate.
Hi, Chris. Good morning. Nice to
Morning.
see you after such a long time.
Yes, it's been a while.
Yeah, anxiety. I think to a certain extent, I think we can all understand that. I think we've all been through. You know, I'm not a person to get anxious or stressed in any way, but I can tell you over the last few weeks, I've had moments when I personally felt it really bad. And I'm part of a support group that regularly rings. We each have a number of people that we call, and you know, at the beginning it's, oh, Kate, I'm absolutely fine, and my brother does this and my sister does this. I can tell you that conversation has changed literally 100. You know, it's just extraordinary, that level of, you know, oh, I don't know what to do, no, I'm so lonely and I really want to go out and my brother didn't come last week. So you've got all of that. I think one of the things that I've become more and more aware of, though, is young people and what this has done to those young people that are working from home. I'm not going to name any names, but I've had probably 3 or 4 one-to-ones on a regular basis with officers at county and district, and they just happen to be single. They live on their own, and you know, I'm sure they love where they live, but they live in rural areas. And the thing that I've noticed, or the thing that they've said to me, is they don't see anyone. You know, they're in their 30s and they don't see anyone. They can't see anyone. They have to work all day. It's dark now at 4:30. They don't see anyone in the evening. And it's something that's kind of unusual for them at their age. You know, they used to go out, meet their mates, going to pubs, going to restaurants, da-da-da. I'm not saying that we as old fuddy-duddies don't do that, but, you know, we kind of, I suppose, I don't know, we adapt better. I'm finding the youngsters are suffering more. I have a son in his mid-30s, and he certainly suffers from anxiety from working from home and not seeing anyone. He certainly is suffering. And have you come across that, or other councillors finding that?
I mean, it is interesting. When we looked at the age profile of people who responded to this survey, in previous surveys, it's normally older people or people with long-term conditions who have responded to surveys. In this survey, nearly 60% of people who responded were of working age. So they were those younger people. So the issues that we were raising, they felt quite strongly about. So I think what you're saying is reflected in that response, the fact that they are concerned about this. Yeah. And a number of the ones we've had, they were concerned about the impact on their mental health and what that would mean for their family.
Yeah, absolutely.
If they were suffering from anxiety and related conditions, would they be able to work in that family environment as they did before? And there were concerns about that. So
and it's difficult. It's a difficult issue to deal with as well. Certainly remotely. That's the problem. Remotely, it's really hard to deal with. But thank you, Chris.
Yeah, thank you. Now, members, for some unknown reason, I went offline when I knew we had several members with their hands up. Having come back online, I've only got one hand up, and that's June. So if you had your hand up previously, please put it again. But over to you, June.
Just one moment. Thank you, Chair. Sorry, had problems. The whatever. Yeah, I was aware. I was at quite a long list of people who put their hands up, Chair. So thank you for calling me early. I think reiterating a point that you made, Chair, in relation to care homes, and we can all, excuse me, we can all speak about our own experiences. I have a friend whose mum has been in a care home for a long time, is very close to no longer being with us, and is very, very upset that she cannot visit her mum. I think, apart from looking at the mental health aspect of that, I think there is a question that maybe could be asked as to a possible solution, and I am not an expert, is could testing of those relatives perhaps be considered so that they may be able to visit that dying parent, because that is exactly what mum is, just so that it can alleviate. Mum is only aware that someone is there, but it's the relatives that have the real mental problem in not being able to see them. So that question has been asked of me, of my friends, saying, well, I'm quite happy to be tested, but if that allows me to go and just see my mum, I'm quite happy to wear whatever anyone wants me to, so long as I can just go and see my mum. I mean, I know that's only one aspect of mental health. I have a son who's quite happy because he's not having to travel 25 miles to and from work every day. But I know, I can see the effect it's having on him, being shut up in a small bedroom, and he does, he's responsible for doing wages, invoices, so it's a very concentrated job. And I can see the effect that it's having on him, to the point where I'm just going to go out for a drive, Mum. He has a disability, he can't walk very far. I'm just going to go out for a drive, Mum, for 10 minutes, just to get out of the house. And I know it can't be helped, well aware of all the reasons why it can't be helped, but it does bother me what's going to come out at the end of mental health issues that we're going to finish up with. Sorry if I've gone on a bit, Chair, but this is just how I see how people close to me are feeling, and I'm like everyone else. I can't get out and talk to people as I would absolutely love to do, which I've done all my life. So thank you, Chair.
No, thank you, June. I think you made the point that I think we're all suffering from. Chris, did you want to come back?
Yeah, no, I think the thought about people being tested, I think, is sensible if it can be done. If we have the capacity to do it and do it quickly, then that makes sense. And there are a whole series of issues about end of life, which need to be thought through quite carefully. I took a phone call from somebody last week, and they were unable to get over the death of their father, because what she said to me was that my dad died alone, surrounded by people wearing spacesuits. And I thought, that is not how a civilized society deals with end of life, and we have to think more creatively about how we do that, so that the relatives and the individual themselves have a better you can't have a better experience, but have a more humane experience of going through that process.
Thank you. Keith?
Thank you, Chair. Your survey hasn't picked up under 25s, but obviously that you may have talked to parents and other things. Has there been much comment about the RISE service and mental health access for the younger people? Because obviously they're a difficult group to survey, and you've done well to get more working age people, but I am very worried about that under 25 age group.
Yeah, we did make specific efforts to try and get feedback from that group, but we did not get any mentions of the RISE service in the responses we had. Now that may well be the way in which we conducted the survey. We may have excluded younger people, But I think there is certainly an issue, because when people were talking about mental health and anxieties, they weren't just talking about themselves, they were talking about members of their family as well. And from my own personal experience, having a 14-year-old going to school, his anxieties when the school was going back in and then isolating again and then going back in, his anxieties and his behaviours have certainly been affected by this. So I think there is a piece of work to be done. We just need to think very carefully about how we do it and how we ensure that we get responses from that group, because the survey methods we chose didn't get them. And it's a piece of work that still needs to be done.
And do enough people know that the RISE service and such exists? Is it, if people aren't talking about it in your survey, is it because they aren't using it, or do they not know it exists?
Well, that's the question, isn't it? Really, I suspect, but I can't evidence that people didn't know about it. But if they didn't, then that's a communication issue that we need to deal with.
Okay, thank you, Les.
Thank you, Chair. I just want to comment on the care homes and access, which is part of my remit. And as somebody said to me the other day, what's keeping you awake at night? And I said it is access to care homes, because it really isn't. I've had some very poignant phone calls and emails in my role. I think the lateral flow testing gives us a way forward. And there is a capacity issue. I'm sure that'll come up in item 6. I don't want to steal from there, but certainly there's a role we can use for lateral flow testing in there. PPE should never be a shortage, because we have our warehouse for it, and it is there to support the care homes we use, which is as well as the ones that are private. But I had a meeting with the assistant directors yesterday. I have another meeting later today on that, because I'm very concerned. I have a brother in a care home who's younger than me and will never come out, and I've had access to him. It can be done. There are costs involved, and there are means of doing it, and I want to ensure that Warwickshire is the front of the compassionate caring, not behind the curve, and that's what my meetings are about this week. I mean, the government has given about 114 iPads to care homes in Warwickshire, and we've put another 40 plus in. That is one way of assisting. It's impersonal, and I do think that end of life care is probably different to continuing care, and we need to address that. I think we can be in a way easier, because it's the companionship at the end of life more important than what you're wearing, in my view. So I'm having those discussions with us. We have put guidance out to care homes, and I've had that refreshed. I did agree with the initial lockdown before the government put its rules out in care homes, because we do know from our own experience that locking down, especially when we had early rises in COVID in rugby, that locking down really helped. So yeah, any advice from any members, would be happy to take any emails at all on this subject, but to be assured that we are really working on being a compassionate, caring authority in regards to this, and changes have to be made.
Thank you for that, Les. That's encouraging. Pam.
Thank you, Chair. Chris, very nice to see you, and thank you very much for your report. It was really, really interesting. Can I ask you a question about the report as a whole? Was it compiled in the first lockdown, or did you take into account any part of this second lockdown?
It was based entirely on...
In regards to mental health?
It was based entirely on the first lockdown.
Yeah. So it would be interesting to I know it's not possible to do something like this just like that, but to see the difference, because in mental health, people who are anxious and have mental health issues, quite a few are affected by weather conditions.
Yeah.
And we were, obviously, in the first lockdown, shall we say, extremely lucky, because we could, most of us, take benefit by sitting in our gardens, and the weather on the whole was good. I mean, even to the extent who's somebody who lives in a flat who has mental illness problems or anxiety problems, you know, even if they can see the sunshine and open a window and feel the sunlight and the warm breeze on, makes a big difference. So I'm really interested in the fact that this second lockdown, although we hope it will be shorter than the first, because of the time of year, and this really, really, really concerns me, because it could also start to affect younger people because weather's bad, they don't get out and about so much, and it does also affect the children because they can't get out and play because, you know, it's tipping it down with rain, blowing a gale, what have you. And it worries me because I'd like to be positive about these lockdowns, but, you know, I have this feeling that perhaps early next year we may be entering another type of lockdown. Again, the weather is going to be bad and I am really concerned. So I would ask you, is there any chance of us getting another report like this that can study the two mental issues from the first lockdown, the second, and if we have any other subsequent ones, where possibly the weather conditions can actually help or hinder?
Yeah, I mean, those are good questions. What we're doing at the moment is we've got a program in which we record the inquiries that we're getting, and part of the program is sentiment analysis. So we're looking to see how people are feeling when they call us, and what we're going to do is I think we will do another survey. The timing of it is the key.
Yeah.
About when winter pressures have really taken had their full impact. So the timing of it will be key for us. But what we're doing at the moment is looking to see how people's feelings are changing as they call us. We're doing a comparison between what we're getting now and what we had during the first lockdown.
Yeah.
We're also looking at the age profile of people calling us, and it's only an initial impression. We haven't got the final stuff, but the people calling us seem to be younger.
Oh dear, that's worrying.
Yeah, seem to be younger, and the sorts of issues they're talking to us about are about quality of life, mental health, all of those related issues, and the key one is for me, what I'm seeing is they can't see a way out of it. They can't see when it's going to come to an end.
Yeah.
And I've heard that a number of times now.
Yeah.
I'm not sure what anybody can say to them, and certainly we can't. So, but we're going to keep a very close eye on that, and I suspect we will do another survey, perhaps not on this scale, but we'll certainly do another survey probably around March, I think, when we've got through winter pressures. I suspect we may have another lockdown after this one, and we will see how people are feeling during that.
Yeah. Thank you very much, Chris.
Nigel.
Thank you, Chair. I just wanted to...
You're muted, Nigel. Thank you.
Says someone in the meeting muted me. I don't know who it was. They clearly didn't want to hear me.
Wasn't me, Nigel.
So first of all, I mean, Les has covered most of the ground, and I absolutely agree with everything he says. But there are two things I wanted to just pick up on. The first is there is a national pilot at the moment. It's being run in 20 care homes across 3 local authorities and is looking at testing and the use of testing to enable care home visits. My understanding it is a testing process for a single named individual to be able to go and visit on a regular basis, and that fits with our other guidance, both locally and nationally about it being a single regular visitor wherever possible. So as soon as we have some outcomes of that, and my understanding is Department of Health Social Care intend to move fairly quickly, then perhaps that is a light at the end of the tunnel, if you like.
Yeah.
The other thing that I just wanted to mention briefly is end-of-life care. So end-of-life care is an exception. It's included in our guidance to care homes about the fact that they can operate differently for end-of-life. And we write to them every week. We reiterate that. They have a newsletter from us. They have communications from us. So I understand care homes are aware of the opportunities that they can take. Clearly, the one that Councillor Cable's brother has understood that message and is operating. But I think there is something about referring people back to the guidance if there are issues around end of life, because there isn't any kind of there isn't the same restriction on those kind of visits as there is on other visits.
Yeah, thank you, Nigel. Jerry.
Thank you, Mr. Chairman. Yeah, I mean, the report is hopefully a useful report, I think, in what it's providing, because the purpose is to try and provide voices, really, of what people are actually saying. So the quantitative bit really sits to one side. But the clear messaging that's coming through this is that anxiety and depression and people and how people are feeling. And as Pam and others have said, I think as the weather draws in more, that actually compounds the situation. And of course, from mental health service provision way, you've got to escalate up the tiers to actually get into the real stuff where you get taken in and get treated. So this is a lower level of mental health issues, which I think is more worrying, really, because that's underlying some of the businesses around that. And of course, as that anxiety and depression build, and if you're lonely at whatever age you are, that actually then compounds up to either towards suicide or particular other elements of not behaving in the way that you would normally do. And I think that's the more element bit. So you asked, Mr. Chairman, what can the county council do? I think it's doing quite a lot at the moment, but I think it is around this key communication. There's those groups that are on the ground that are working with COVID groups now. They actually, I think, start to need some of that help and support of how they actually phone people in the community and actually give some of that support. I know in the area I represent, the COVID group has started to do that as it's developed its way of working going forward, and I think that's what potentially I think the county council needs to do. We won't be able to solve the whole thing, but actually we could help on the ground through community capacity help and support, and that's Kashal and others, and it's that cross-cutting theme which works across all portfolios and not just one. And I think possibly the scrutiny committee could sort of hold people to account around that and hold the county to account. Are you making sure that on the ground that low level, if you like, mental health issues, isolation, loneliness is actually working forward? Later on I was going to touch upon in the performance reporting about domestic abuse and those things as well. But I think what's clear from this report is, and certainly the directors of Health Watch have talked about, is actually they want to continue some of these questions through and collecting that evidence, because we've got a baseline, if you like, of where we started from, and you don't want to lose that baseline. So as you go through, you need to collate that evidence in, because I think this is, for me, I think this is some of the most valuable data-rich stuff that can actually be provided to then support things in delivering services.
Thank you, Jerry. Those points are well made. Did you want to come back, Chris?
Just to agree with everything Jerry just said, he's spot on.
Thank you. Margaret.
Thank you, Chairman. I'd just first of all like to say I was very reassured by what Nigel said on end of life, because I was agreeing with Les that we need to show compassion and it's separate from care homes in general. So it sounds as if we've got that guidance going out, so that's been really helpful. But I wanted to talk again about mental health, and obviously it's not a surprise that it's a highlight of your report, Chris, which was really useful. I mean, for me, there are several categories of this. There are people with existing mental health problems who are not responding responding particularly well to the way the services are having to be delivered now. There's very little, if any, face-to-face for people who already had a mental health problem and are now having to deal with this, going through this crisis. And I would really like to hear from CWPT about what's happening to those people, and have they got some flexibility on how they can support people who had existing mental health problems so they're not made worse. And then, of course, we've got this whole cohort of people, which Chris has highlighted, who are not responding well to the restrictions, particularly the second lot of restrictions, possibly on the horizon, the third lot of restrictions. And it's somehow how we galvanise, in a way, as Jerry was saying, how do we galvanise the third sector and the early intervention people to come up with some packages to try and help people in that isolation, etc. And then the last thing I'd like to say is, I'm not clear, I don't know if anybody is, the people who are responding badly now to the current situation, are they likely to have ongoing mental health issues that will need some sort of treatment and support, even when the lockdowns are finished, whenever that might be? And I don't know whether this is a permanent thing that's happening to people now, or whether it is only while the restrictions are on. Not that that's not bad enough, but if you sort of mean, we might be building up quite a crisis for the future. And I'm not sure who would be able to answer that question and look into it. Maybe we need CWPT to help us. Thank you, Chairman.
Thank you, Margaret. Chris, do you any comment?
The issue about the legacy of the pandemic is one that we raise every time we meet with one of the major providers, because there are backlogs in elective treatments and there will be delays in those, and we need to be upfront about that. We do want people to access non-COVID services, but we have to be realistic about how that can be done. And I think in terms of the legacy, the mental health legacy of this pandemic, I don't think we're going to know the scale of that for a little while yet, because as Pam indicated, when you get seasonal affective disorder and winter pressures on top of the lockdown, then you start to identify a legacy problem. And there's another group of people that I did want to just highlight while we're in this discussion, and that is carers. Carers for people who are living with those sorts of conditions and those sorts of anxieties. And they themselves are beginning to talk to us about strains they're under and the stresses they're under. And I think it would be helpful, I think, to do a check with carers about how they're feeling and about how it's going for them. And because I had one, and she was living with somebody who had an addiction problem. And she was really struggling to cope with the behavioural challenges that were coming along because his addiction couldn't be satisfied. So I think there are all kinds of issues there that somebody like CWPT and the county council working and the third sector working together should be able to begin to address.
Thank you, Chris. Now I still have 4 speakers. John Cook, Pam Williams, Les Caborn and Becky Hale, and after that I'm drawing it to a close, as we still have further 2 items or 3 items actually on our agenda. So John.
Yes, thank you, Chairman. Firstly, I'd like to congratulate Chris Bain and Health Watch Warwickshire. This report, he said in his presentation that he had tried to make it clear and easy to read. Well, you succeeded on that, Chris, because frankly it was easy to read. In fact, it's one of the reports that have been the best for myself to read since I've been a member of this committee. So congratulations on that. I think the last slide which you had, which the one that to my mind is the one I want to talk about, which was actually about the mental health side of things. My friends who are on this meeting might disagree with me, but I'm on the whole a reasonably level-headed person and I can be cranky at times, but not most of the time. But I have to tell you that I have some agreement with Pam on this, because I think this second lockdown, as far as I've been concerned, has been much more stressful to me. Now, whether it's the weather, I don't know, but I am not my normal self, whatever my normal self is, but I'm definitely not. I have found various things. I'm getting more and more cranky. That's definitely the case. Now, those who know me will know that I can be quite cranky, but I am definitely more cranky. I'm definitely more impatient, and that worries me. In fact, I sent an email last evening that I actually looked at it after I sent it, and then I wrote another email to the person to say, I'm sorry, I'm not normally like that, because it was quite a critical email, and I wouldn't have normally done that. So quite clearly it's affecting me. And I do think you also had a passage in your report about people who are working from home and the stress of that. And I don't know if you saw over the weekend, a number of the national newspapers covered report from one of the universities saying that people who are doing lots of these online conferences. Now, I do lots of these each week, and I'm sure we're all used to doing lots of them. I've got 4 today. One day last week I had 6 of them, saying about how difficult people do. And I am so tired at the end of the day when having done all these. I do feel stressed about that. Now, I never thought I'd ever be the sort of person that gets stressed about things like that, but I am irritated about some of these things. And I just wonder if you've had anybody who's contacted you during this who've actually specifically mentioned the online conferencing, because to my mind, it's just perhaps it's a symptom of the thing, but I just find that difficult. The other thing is that you also mentioned about communication and so on. I think the communications is a key aspect to it, and you fairly early on in your presentation you mentioned about people who said, well, they haven't got any problem finding the information. It's about assimilating whether it's the current information and whether it's still and I have to agree with you at that. And I hate to be critical of different organisations, but I think the government haven't helped in this. That's my personal view. But I would say to you, superb report, and I hope that all members of the council have a chance to read it, because I think they will all find that there's an awful lot in it that they will recognise. So that's my cranky self signing off, and congratulations on the report.
Chris, before you respond, don't forget he's feeling cranky.
Wally knows me well.
Well, can I just say, Councillor Cook, if that's you being cranky, I don't know what it's like for everybody else. In terms of the online conferencing, we have done, we've had some training courses on it, and apparently we pick up 80% of communication is through body language. And that when you don't have access to body language, you have to work much harder to understand the communication. Yeah. And they're telling me that's why we're all tired at the end of the day.
And cranky.
And I share the crankiness, incidentally. I do share the crankiness. Yes, I've become less tolerant of idiots, which is a real problem.
Thank you. Sorry, carry on, Chris.
But the issue, the more serious issue, is about the version control on information. And we do have to really get on top of this. And we're trying to do that on our website, because we do try and put current information on service availability on our website, and we do research version control to make sure that we have the latest version on our website at all times. And it is time consuming and it is difficult, but it is so important that we get it right. So I'm agreeing with you entirely on version control. That needs to be dealt with.
Thank you. Pam Williams.
Yes, thank you very much, Chair. And thank you, Chris, for your excellent report. It's very interesting. A couple of things I just want to raise. I'm really glad that you talked about carers, because I'm hearing from quite a number of carers that they are really feeling stressed, mainly because the people that they're going in to care for are not having the human contact that they would normally have from family and friends. And so it's all on them. Even when they're going in 3 times a day, you know, people are missing their children, their grandchildren, their family and their friends. And they're noticing that people are becoming more and more anxious and need a lot of reassurance. And unfortunately, a lot of the people that they're talking about are not able to use the telephone or to use video calling or anything like that. And they're probably the most difficult group to get access to. But I'm also, the carers themselves I'm worried about, because I noticed that one of the carers that goes to my mum, she's lost about 2 stone recently, and she is incredibly anxious about everything and told me that a lot of her colleagues are feeling exactly the same. And they feel the responsibility very strongly for the people that they're going to see. And I wonder if there's some way that we could consider having PPE provided for family and friends when they go in to see, and whether we can allow that sort of access or encourage that sort of access, because I think it would take the pressure off. I don't know how many people we've got in Warwickshire that are living on their own and are having carers. Do we know that? Have we got any information about that? Because that might be a starting point in actually looking at what we can do to provide. If we've got lots of PPE, perhaps we could help people to go and visit, because there is a fear as well within that within that situation of having people in the house. So, and most people, maybe they have masks, but they don't have everything else that carers would normally use. So, and some people can't afford it. So, I don't know whether we can think along those lines. But they're not the sort of people who are going to ring you up and say, you know, I'm anxious, or use any sort of communication that we're all using to make their views known. But thank you very much for the report, and thank you for all the work.
Thank you, Pam. Anything there you want to come on, Chris?
Yes, I mean, I'm grateful for those comments, and I share your concerns about carers. I don't know what the scale of the problem is. I do know there's a problem because they're calling us. And what we don't know is what the scale of the problem is. And part of our anxiety as an organisation is it's what issues are being hidden by this pandemic and the isolation. I mean, are we missing, for example, safeguarding issues? Are we missing domestic abuse and domestic violence issues? So it's all of those things we're not clear about. The County Council is working hard to deal with those, but it's not easy. These things are not easy. And it's something we need to stay right on top of. And certainly as we get calls that relate to safeguarding, domestic abuse, domestic violence, we get straight on the phone to the County Council to talk through what we're hearing. And by and large, they're responding reasonably well, but I'm still sure there's a hidden problem there about carers that we're not getting at. I'm still sure there is.
Thank you. Right, last 2 speakers, Les and then Becky. Les?
Yeah, thank you, Chairman. Yeah, I'll certainly take up the carers issues, and I'm sure Becky will respond as well. In fact, she has put a note on. Just to say, while I've been talking, I've dug out the last letter we sent to care providers, and I will share that with the committee, but to do the respect is it's not for general public circulation, just so members are informed and they can think about it, and any queries come back to myself. Thank you, Chair.
Thank you, Les. Becky?
Thank you, Chair. A couple of things. So I'll come back first on the carers point. We'll look to share some information around informal carers and the support available to them. We've been doing a lot of work around that and a lot of communication, so I'll look to share that with the committee. Just want to make the point that it is Carers' Rights Day on the 26th of November. Hopefully you've received the information that we've shared, and would really like you to help us in promoting that, so that carers are available or aware of their rights and what support is available to them. The other point that I just wanted to make, to pick up on some of the discussions that we've just had, following on from Margaret and about mental health, and just to make you aware that actually this week is Alcohol Awareness Week. And we are particularly noting the link between alcohol and mental health, and asking people to speak up. So we know that in Warwickshire, more than a third of adults are drinking more than the 14 units a week, and that there is a link between people's mental health, anxiety and depression the more that they are drinking. So I just wanted the committee to be aware that is this week. And if you can share any information, which I'll send to Paul after this, it would be really, really helpful, because we recognise that during the lockdown, people's drinking habits have changed as well, and that is having an impact. Thank you, Chair.
Thank you very much for that, Becky. I'm now drawing this item to a close. Chris, thank you very much. I think you, from the comments that our members have made, how much they appreciate the work that has been done by Healthwatch on this survey. Certainly raised, I think, a number of issues which we should be, I'm sure, in dialogue with you over the next few months to see what information you've been able to follow up on, which will be, more than useful for us, in particular in the isolation and mental health issues that we are all being confronted with. So thank you very much, and please pass on our thanks to your team, who have done an excellent job on providing this survey. Thank you very much indeed, Chris. Thank you.
Thank you, Chair.
On to item 5 of our agenda, which is you, Becky. You're muted.
Okay. I think it's actually Sade, is it? Agenda item 5.
I've got mid-year performance progress report. Down to you.
Okay, that's fine. Sorry, I thought that was last. Okay, so I've got something to share with you on screen. Wait one moment. Okay, let me know when you can see that. Any luck?
Not yet.
Okay, we'll try again.
Coming up. Yes, we've got it.
Great. Okay. So people have got the report. I'm just going to very briefly take you through some of the key updates, and then obviously give most time for questions. Recommendation of the report is that the committee considers and makes comments on the progress that has been shared. This presentation is obviously focused on those areas that are pertinent to the remit of this committee. Just a reminder of the council plan and our high-level outcomes, and that there are 58 business measures that help us to understand how we are performing against the delivery of the council plan. So in terms of the People Directorate overview and this overview and scrutiny committee, there are 14 key business measures that are in the remit. All key business measures are available for reporting, and of those, 57% are on track and 43% are not. There has been an improvement in the number of KBMs reported as being on track this quarter, and there has been 4 new measures added over the period linked to priorities. So just wanted to pull out some of the key areas of success noted in the report, but I'm sure there will be kind of queries and questions around some of these. So the first one around the number of people in receipt of adult social care, with the numbers remaining relatively stable. The indication is that the service is able to manage current demand and that we are in a good position as we respond to winter pressures. Although, as we all know, the response to the winter is going to be a significant effort for adult social care and commission providers, but there is confidence around the numbers and the demand. The suicide rates, 3-year aggregated performance for 17-19 has been now released. The Warwickshire rate is lower than the England rates, and is fourth lowest rate from a regional perspective. I think we all recognise, however, that the impact of the COVID pandemic, as we've just talked about, on mental health, well-being and suicide has been significant. So while this indicates where we are around performance, it is absolutely a priority for us in terms of suicide prevention and doing as much as we can across the system to prevent suicide. The number of domestic abuse incidents reported, so it is positive to see that there's been a 12% increase when we look at the previous baseline, and obviously that's been against the backdrop of the pandemic. And while it is positive that we're seeing an increase, we still want further increases, and we continue to focus on communication and making sure that all areas of the system are actively communicating to increase domestic abuse referrals. So a couple of the areas that are paused. So there are two measures that are paused that are part of our commissioning support unit remit, and those relate to the percentage of placements for adults in provision of good or outstanding quality as rated by CQC, and then similarly for those in provision rated by Ofsted. And the key reason for those being paused is at this point in time, the CQC and Ofsted are not undertaking their inspection regime, and as such, the performance won't change. In terms of areas for improvement, just a few key ones to draw out from the report. The numbers of people with a learning disability and or autism in an inpatient unit commissioned by the CCG remains an area for improvement. Coventry and Warwickshire is on regional escalation around that and is having monthly meetings with the NHS in relation to that. We are seeing some improvement, and actually the targets that we did have for September and October were reached, but it is an area that we are continuing to focus on that does look like we may miss the target by the end of the year. The number of people assisted to live independently through provision of social care equipment is another area of improvement. The percentage of successful completions as a proportion of all in treatment, and this relates to adults who are in treatment with CGL. I think it's important to note that the figures are 3 months in arrears, and that because of the impact of COVID, people have been maintained in treatment longer than they would usually be, and the impact of that is obviously that there has been fewer completions and closures of those treatments. And as indicated above, we are still focused on increasing the number of domestic abuse incidents reported. In terms of the revenue budget, and I'm sure there will be questions around this from the committee, but you can see that both adult social care and people strategy and commissioning are red, and that relates to the tolerance levels in terms of the forecasts. You can see the adult social care forecast, but there is a significant COVID impact on that forecast for this year, and I'm sure Pete will be able to talk a little bit more about that. In terms of people strategy and commissioning, we have an underspend that is being forecast, and that includes public health spend as well. So some of that relates to test and trace money that will be moved over to next year. So some of it will be spent next year, but we're forecasting an underspend this year. In terms of, sorry, gone a little bit past, delivery of the savings that we have are all on target to be delivered, and similarly our capital programme also on target to be delivered. Any questions?
Thank you, Becky, thank you. Jerry, I think you were going to ask a question.
Yes, just try and get unmuted. Thank you, Mr. Chairman. There was a couple of, can I thank Becky for the report, really. It was partly to do around the new legislation coming in for domestic abuse, which actually gives statutory duties to local authorities around that. and that relates then to what's commonly known, I think, as the toxic trio. So we have domestic abuse, drug and alcohol, and mental health. So I suppose that could touch on the last session that we talked about. And looking at the form, yeah, we see increasing numbers. That's fine because we want more reporting. We want to find out more what's going on. And I'm just wondering, going forward, actually, we need to be smarter about some of the way we report now on what we're going to report in relation to those. So really, I'm making a comment rather than actually specifically and asking, could we have actually see some, I suppose, some new performance indicator around that? And I think it might be useful, Mr. Chairman, if we could have a briefing or something on what the updated position is about the new duties for the local authority that will have to perform in relation to domestic abuse. Yeah. The other bit is I'd like to know a little bit more around you put in the money side of stuff, the possibility of people have reduced packages to support to reduce the footfall and therefore COVID risk in their homes. And I'd just like to unpick that a little bit more. It was one of the paragraphs in the financial report. Whether that's Pete or not, I'm not sure. But does that also relate to independent living and some of the work possibly we're doing with housing providers and other people as well? So I just wanted to understand a little bit more about that, which, because it does finish up by saying all of support as they are reluctant to start their support journey during these times. So we have this dichotomy of we want to keep people at home, and there's something. Is it all down to COVID, or is it something else going on really? There is other stuff, but I can always pick that up later. Okay, those were the two main ones.
Thank you, Joey. Becky?
Yeah, I'm sure Pete will come on around the finance one. Just picking up your point, Jerry, around domestic abuse, substance misuse and mental health. As you can see, some of the new measures are particularly have been brought in to start having reporting around those. So we will look at how we do something that gives a greater sense of what is going on across those three areas. We have done some work over the course of this year, actually, which has started to introduce NDTs with providers of domestic abuse, substance misuse and mental health, and actually getting people together around really understanding people and their needs where they have kind of dual issues. So that is something that we have been progressing and I think is a really positive step for both children and adults over the course of the year. You're right in terms of the new duties. We're doing a lot of work around domestic abuse at the moment. We're doing work to prepare for the recommissioning of our domestic abuse support services, including the accommodation support services, and also the responsibilities that we now have, as you indicate. So more than happy to ask the team to send you a briefing on that, and please be assured that we are continue to be focused on that and are in a good place in terms of the requirements upon us.
Thank you, Becky. Yes, a briefing note on the responsibilities to all members would be appreciated. Keith.
Thank you very much. From the report, it's clear that there's a reduction in people going into care homes or having care at home, which may be a good thing or maybe an absolute dreadful thing, depending on their circumstances. We're also seeing from the ONS more people dying at home than in care homes from non-COVID related things. Do we have an idea of how big a sort of backlog or sort of latent demand there is? Because obviously if we start to get vaccinations going in, say, January, February, some people may then feel happier about either having a carer come in or going into a care home. And related to that, are we having problems with care homes financially having difficulties? Because obviously they've lost lots of patient residents as they normally would and haven't had that general flow back in. Thank you, Chair.
Thank you. Becky, did you want to come back on that?
Yeah, happy to come back on that. We are seeing, Keith, that people who may have self-funded and chosen to go into a care home, maybe at this point in time more reluctant to do so. So we are seeing an impact on admission rates into care homes. As you say, we do not have concerns around care home capacity in the market, but there are occupancy considerations for providers. So we are working closely with providers, particularly those who are experiencing some financial difficulties. We have a provider viability matrix that we continue to monitor so that we can really keep an eye on all of our care providers and their current sustainability status, so that we can really make sure that we kind of support them to be sustainable. So that work is happening. In terms of community support, we aren't seeing the same level of kind of reductions, I think, in terms of people accessing community support. So continued numbers in extra care housing, in specialist housing, in supported living, and actually in domiciliary. I think largely we're seeing the impact on care homes.
Thank you.
Pete wants to add anything.
Yeah, Pete, do you want to come in?
Yeah. So just on the point around that Councillor Roothouse mentioned, that it was on page 6 of the report around the possibility that people reduce packages of support to reduce footfall. I think we have seen a reduction in some support people have been requesting. I think it's more around the community aspect, so it's more around day opportunities or daycare and respite, and less around domiciliary care. So actually, if I look at the activity around domiciliary care, since the first wave of COVID, there's been a great increase. So I wouldn't be suggesting that that there's been a reduction in the amount of support or the number of people supported through domiciliary care during this time. What I would say is I think we're seeing a distinct difference between the first wave of COVID and the second. So we're starting to see people come through now who perhaps on the first wave wouldn't have. So I think we've got our business as usual activity plus some other elements. I think it's because people are kind of seeing the longer term view that COVID may be around for a very long time, and therefore there's no point holding off because actually I've got a need, I might as well deal with it now. So we're seeing more people coming through our hospital teams and our community teams, and more activity through the customer service centre as well. In terms of the finances, it is very complicated. So we've got multiple income streams that we have normally. So the BCF, the IBCF, and the winter pressure funds, and we've also got money coming through the hospital discharge grant. I think some of this is about aligning where that expenditure is going, so whether it goes through commissioning or through my delivery teams. What I would say is that I think our activity this year overall is likely to be a little bit more than usual, but it isn't significantly more or significantly less. So I think when we look back at some point, I think we'll see some interesting blips in certain bits of activity. But overall, I think it is probably quite similar. Yes, and I think there is some crossover potentially around some of the funding as well that we're getting. But now the guidance has changed around people's ability to have free care and support. So up until September, if you came through an acute hospital trust or we were trying to prevent a hospital admission, you got your care for free. That's now changed since September, and now it's up to 6 weeks. So I think that will start to normalise some of our income and expenditure as well. It's the toughest year I've ever come across in terms of social care finances, because we're juggling so many different balls. But yeah.
Okay, Pete, thank you. Now I have one more speaker, Joe Barker, and after that I will draw this item to a close. Joe.
I just wanted to pick up slightly on what Pete was saying and what others have said about the impact of COVID. I've noticed, particularly with some of the oldies who I visit, that over the first lockdown, their physical health, which was actually pretty good, deteriorated massively. And I think of a couple who are in their 90s because they were not going out. They felt they couldn't, they were told they were supposed to stay in all the time, and so they did. And so I think that we're going to not only reap the mental health whirlwind from this, but I would say that there is a bubble, which maybe you're already seeing, Pete, I don't know, but it's coming through, of people that we wouldn't necessarily have expected to end up needing the care yet, if ever. And I find it very depressing that people who were actually managing to be physically brilliantly active into their 90s have effectively had to stop because of their age and because of the safety argument. So I think maybe there is the scope potentially for coming into the community at some later stage with some kind of, not reablement as we know it, but reablement as in maybe classes and confidence renewal, because that's also gone. So it's slightly despondent sounding, forgive me, but I think that's where some of it's coming from.
Okay, thank you, Joe. Did you want to come back, Pete?
Yeah, I think we're starting to see now some people come through who historically would have stayed out of our service a bit longer, which is sad. What I would say, there is some positive news though, which is actually because of the way we're doing hospital discharges now, we're using a model where we're doing our assessments, our social care assessments in the community. So we're probably supporting more people out of hospital with reablement and domiciliary care because of the way the money's flowing at the moment through the NHS, which is a real positive thing. So actually, I think we're starting to manage our demand better by doing that. So we're enabling people to get home quicker and to get back to their norm as quick as possible, which means actually their need for social care is reduced. So it's good news for them and for us. So it is the out of this, I think hospital discharges will change forever positively around that, and I think that's a real good news story out of all the bad news that goes on.
Can I just say how pleased I am to hear it, having, as some of you know, been through it with my own mum before this, so I'm familiar with how brilliant reablement is, and I always say that, but for me, that's always been the key, is to get everybody out of hospital as fast as humanly possible. Apart from anything else, just speaking as a straight Tory, it's cheaper. What could be wrong with it? Cheaper and better.
Thank you, Joe. Okay, thank you, Becky, Pete. The report has been acknowledged and commented on. Thank you very much indeed for that. Now moving on to item 6, which is the COVID report by Sade. Are you there, Sade?
I am indeed.
Thank you. Over to you.
And I've just shared my screen. Can everybody see that?
Yes, we can. Thank you.
That's great. So I have tried to capture the specific asks in my presentation, but I'm happy to take any questions that are outside what I am going to cover. So you asked for some an update on wave 1 versus wave 2, a test and trace update, and some information around the mobile app uptake. So I've tried to cover all of those, and anything else that's not in here we can discuss. So wave 1 versus wave 2 comparison. The chances of survival are better so far, and that is because the age composition is different. People that are testing positive and needing hospitalization in the second wave tend to be younger. We also have reason to believe that health professionals know what they're doing, compared to the first wave, where there was a lot of stab in the dark and not really being sure or confident about the care of people needing oxygen support, for example. It is now much more clearer about in relation to what it is, that's the sort of care that people need when they go into hospital. So care is generally better, outcomes are better. Whilst admissions were doubling in less than a week in wave 1, they've been doubling at half that rate in October. At the peak of the first wave, death rates were in excess of the national average and were twice the recorded number of daily COVID deaths, but we're not seeing that pattern in wave 2. Excess deaths have roughly been in line with daily recorded deaths. So that's the general picture in terms of comparing wave 1 and wave 2. But more specifically, I've asked our BI colleagues to do some digging and breakdown of numbers in wave 1 versus wave 2 for Warwickshire. And as you can see from the table on this slide, numbers generally larger in wave 2, and that is down to more testing. So in wave 1, if you recall, most of the testing were pillar 1 testing and tests that happened in hospital. Wave 2 is a lot of community-based testing. So going back on my slide, sorry. Community-based testing, we've got our RICO arena, we've got our mobile testing units, we've got our local testing sites. So it's fair to say that we're picking up more cases in wave 2, and that's responsible for the higher numbers of cases that we've recorded till date. And this pattern is repeated across all our districts and boroughs. Something else that's quite interesting about the age breakdown is the age breakdown in wave 1 versus wave 2. And I have highlighted the bits that I think merits a bit more attention. The age breakdown in wave 1, when you look at 20 to 29-year-olds, only 9.6% of people in that particular age band were positive for COVID in wave 1. This is compared to 20% in wave 2. Similar difference, if I can use that both words in the same sentence, 30 to 39, 10% in wave 1, 15% in wave 2. But what's more interesting is when you look at the older age groups, age 70 to 79, 12.5% in wave 1, 3.6% in wave 2, 80 to 89, 18% in wave 1, and only 1.9% in wave 2 till date. So there are all sorts of reasons for this. Lockdown, shielding, obviously has had a huge impact on protecting our older people and our more vulnerable groups, and that is why we are seeing lower numbers of cases in older age groups. Indeed, the key to managing hospital capacity is to keep the infection rate as low as possible in people over the age of 60. That is the current picture in regards to age breakdown for Warwickshire, provided by Public Health England. And the key point of this slide is that the darker shades represent higher case numbers. And you can see that for Warwickshire as a whole, the darker shades are in the age group 16 to 29, but it is slowly creeping up. So if you look at age 60 plus, while it's still mostly yellow and amber, and I would like to keep it that way, it is going to be creeping up as the weeks progress, especially if people do not adhere to the principles of social distancing, wearing of masks and face coverings, and keeping their circle small. That's just the slide that talks about testing numbers. Our testing rates are still relatively good compared to the rest of the West Midlands. Also presents positivity. North Warwickshire has got the highest positivity at 11.6. No surprise that they've got the highest case rates and case numbers across the region. Stratford has now got the lowest positivity at 6.3. So I'll move on to the test and trace update very quickly. That's a summary of the testing channels that we currently have available to us in Warwickshire. We've got 5 mobile testing unit locations, so our MTU rotates, and we've got a schedule that we prepare a month in advance. So we will share this with yourselves so that people can know where the testing unit is going to be at any particular week. We have 3 local test services, so that's the walk-in test site that is designed to be in place for up to 3 to 6 months, where we want hopefully to move to 6, and there's plans in place to do that. We have our regional test site, the RICO arena, and we have testing by post, which is home testing, where people can go online and request a test kit to be posted to their home addresses. The key point about this is that all 4 testing channels all use the same type of test, the PCR tests, which require processing in a lab. Turnaround times have improved, so a test taken at a regional testing site results will come back in about 24 hours now. The last column on this slide talks about asymptomatic testing, and I'll talk a bit more about that. That's all the rage at the moment, and we've already had some conversations already about asymptomatic testing using lift lateral flow tests. All of that is coming online. I'll say a bit more about that in a minute. I'll talk about contact tracing activity, because there's no point doing all of this testing if you're not going to be contact tracing. That is the bedrock of keeping the infection under control, by identifying all contacts with a positive case. What we have done is establish a backward contact tracing team that sits within our business and customer services directorate within resources. And the team has been geared up to have all of the information and resources needed for them to carry out backwards contact tracing. They've hit the ground running. They're doing some really great work. We've estimated that they will need to backward contact trace an average of 150 to 200 cases per day, which is the average number of cases that's coming into us in Warwickshire on a daily basis, and that work is ongoing. But we need to build capacity, especially with asymptomatic testing coming in. We will be picking up more positives, and the contact tracing resource will need to be beefed up. And that is because there's still gaps in numbers reached by the National Test and Trace team. They are reaching at least 80 to 85% of cases as at the 15th of November. But that means there's still about 15, 20% of cases that are not being reached and are not being contact traced. So it is absolutely imperative that we beef up the local contact tracing capacity so that we can pick all of this up. I'll talk a bit about asymptomatic testing. It is key to stopping the spread of COVID if we can get it right, and it may allow contact tracing to start immediately because results are ready within 30 minutes. There are also concerns about the sensitivity and the specificity of the type of test that's going to be used. Lifts, they're not very sensitive, but they're very specific. What that means is that we might be in a position where we will be having false negatives, so people that actually have disease and the test is not picking them up. So there are all sorts of conversations happening in the backgrounds to ensure that we do the right thing. So if people are testing negative, do we need to repeat the test so that we're absolutely 100% sure that they're negative? If people test positive, do we need a confirmatory test using PCR technology just to be sure that the person has actually tested positive? So all of those are happening and being embedded into a standard operating procedure. The last thing I was going to talk about, which is what you asked for, is mobile app updates. Downloaded by 40% of eligible adults with smartphones, and we did some crunching of numbers. Downloaded 19 million times across since it went live across England, and that would suggest that we think that at least 190 downloads of the app has happened in Warwickshire. But we do know that 56% of the general population, or 80% of current smartphone users, need to download it for it to be effective. So there is some work in here for us to beef up our messages around downloading the app. We do put out a range of messages every week, but perhaps there is some work for us to beef this up. Over 160,000 businesses have downloaded the QR codes. And this is my last slide. This is just to give you a flavor of what our current priorities are. We continue to support our 3 place-based IMTs, targeted messaging to over 60s, just to remind them that the numbers are low now, but we don't want it to start to creep up because that's when our hospital capacity starts to creak. We are seeing a lot of workplace outbreaks, so there is some work happening to prevent that from happening. LFTs, I've talked about that. That is taking a lot of our time and resource at the moment to see how we can roll this out. And exiting lockdown as well. Lots of conversation happening in the background about how we're going to exit lockdown, what tier we're going to be exiting into, and how do we manage that. So that's all I'm sharing today. I will stop sharing my slides now. Thank you very much.
Thank you, Sade. Joe, your first full question.
Thank you. I've got 3 questions. They'll be brief. The first one is about test sites. Yet again, because I live right at the edge of the county, our nearest test sites aren't in the county. I shall be taking Junior to one today because Junior has a sore throat, which any other year would be a cold, but we're going to go and check. So we're going to Stowe. So we'll be having testing in Gloucestershire. Can you comment on whether we're looking at the same, how can I put this, degree of effectiveness in the testing? Because that's quite interesting. Because we'll register as a Warwickshire case, but we're not having a Warwickshire test. Second one is I can't believe I'm going to say this, but I think we should cancel Christmas on the basis, and I'm sounding worse than John Cook, because on the basis we've worked so blooming hard, our 5 days with our families really worth it? Maybe I don't love my family enough, I don't know. Is it really worth it for the fact that we're then all going to be locked up again for months? Or that's how it feels. So I've made the decision for our family that we're staying at home. And finally, this is the only context in which I would actually ask this question because of what we've been talking about. And I don't expect you to answer it, Sade, but I just want to posit it for everybody. But do any of us think that the impact of the cure, i.e. the mental health, domestic violence, the other things we're talking about, is now actually worse than the disease? And are the costs worth it? That is rhetorical, but I do think we need to start talking about it because of getting out of lockdown at some point.
Thank you, Jo. Sade?
So the first question around your test site, you've been sent to a site in Stoke, you said, Jo.
Stowe on the Wold. Lovely.
Oh,
okay. Sorry, Stowe. No, if we can't go to Stoke, I'd be quite cross. I don't know Stoke.
You said Stoke. Okay.
No, Stowe on the Wold, which is only 15 miles.
Okay.
But it's in Gloucestershire.
I can take this back. What I've been told is that there is ample capacity in the system. Many of our test sites are not even seeing people coming through. Demand does not meet with supply. There's a lot of supply, but demand is not catching up at all. So ideally, you should get a test site that's closer to your home. Let me take this back to our testing coordinator.
This is the closest to our home. It happens to be in Gloucestershire because we live close to the county border, and I'm just making the border issue, which comes up quite a lot on this committee, and I just wonder whether that's a good thing, a bad thing, whether you get the reports, whether it will actually work. Sorry, I wasn't clear. Forgive me.
No, that's okay. The other one you said was about cancelling Christmas. I don't want to be the Christmas Grinch, Jo. I don't know what to say to that.
That's your job. You're the director.
I was quite happy to be the Halloween Grinch, but maybe, I don't know. We all have to do the right thing, I think, just to make sure that we get what we want. And I know that people are tired and people are fatigued about the messaging. But I think if we all do the right thing, we will get what we want. And I'm not sure how best we can reframe the message, because I think we've said it in so many ways that we're probably running out of ways to sell the same message. There is probably something about working with comms to be a bit more creative around how we do this. But and then the third point, you said it was rhetorical, so I'm sure that you probably don't want an answer from me.
You do not want to answer.
Okay.
But I just wanted everybody to hear it, because you hear it quite a lot, from me.
Pam Williams.
Hi, Sade. Thank you very much, Chair. Just a couple of things. I think I've mentioned this before. It's the multiple calls that people are having in the tracing process. People are still complaining that they're having multiple calls and they think unnecessarily, so they're just cutting them all off now, which I don't think is very helpful. The other concern, again, is the students coming home on December the 11th. Are they going to be able to have these lateral flow tests before they come home, just to reassure parents? It's the parents that are raising the concerns with me about having their family home. I mean, I know when my daughter came home, she bought all her washing, so actually it would have been better if she stayed at university. But, you know, I'm sure it's not the washing that's bothering them this time. It's catching COVID from their offspring. So would that be available for them? And then I know Jo mentioned the cancelling Christmas. She's cancelling Christmas, but most people I've spoken to are going to have Christmas regardless. They are going to carry on and they're going to have Christmas. They're all going to get together. And I think if that is going to be the case, we have to walk a very careful line with this. They're all concerned about, going to church at Christmas as well and how that will work. But I think my view is if people are going to have Christmas, then we ought to give them some very clear guidance about how they can do that. You know, I'll probably put my family in the garden, but yeah. So just those few things really, Sade, thank you very much. But thanks for the presentation, it was great, really succinct and really useful. Thank you.
Thank you, Pam. So the first point around multiple calls It was raised at member board yesterday. I have fed back to the HSC to say this is what we're hearing. They do take my point. They said they'll come back to me. So again, I will repeat it. This is not the first time we're hearing it, and I'm sure this is not the first time they're hearing it as well. Yeah. And we just keep feeding that back to them, and I will take it back again. Testing for students. When the lateral flow test rollout started, universities were approached directly, independent of the offer to direct public health and local authorities, and they were asked to express an interest in lateral flow testing for the students. They've been given strict operational timelines. So they've been told that between the 30th of November and the 6th of December, all students must be tested. I will pick up with our uni, with Warwick Uni, as to whether or not their expression of interest, whether they've heard anything in terms of what they're getting back. But I did speak to Professor Simon Brake, and he did confirm that they have requested at least 20,000 test kits for Warwick Uni, and I think most universities are doing the same. So they have clear instructions to make sure that all students are tested before they return home using LIFT technology. There's work happening already with Deloitte around making sure that anybody that tests negative has a repeat test, just to be sure that it's not a false negative. So that work is happening in relation to our universities.
The concerns are mostly about Liverpool, Manchester and Nottingham universities. That's where I'm getting the concerns raised. Okay.
All I can say is there's a program of work to ensure that students are tested before they return home.
Okay.
And that is ongoing across unis. The last point about Christmas, and I think you're right, that comes and how we send out the message to reassure people and ensure that people celebrate Christmas safely. We've done it with Halloween, we've done it with Remembrance. We can do it for Christmas, and I think it's about the messaging. So that would be my position anyway. How can you celebrate Christmas safely rather than say don't do it at all?
Yeah, thanks very much indeed.
Okay.
Thank you.
Keith.
Thank you very much, Shade. Thanks for sending the slides in advance. It's very useful, particularly detailed numbers, to see them the day before, so that's really been helpful. On the actual data, the age profile was very useful in the 10-year bands, but your heat map is in 15-year bands, which doesn't really let us pick out, particularly around sort of sixth formers. We talk about students so much, but actually sixth formers are actually still living at home for the most part, and that's obviously quite a big vector then to get it into the 20 and 30-year-olds. So I don't know what we're doing about sixth formers or that sort of middle-aged teenagers, but I think particularly looking at Christmas, trying to get it out of that age group would be really useful. And it's when schools end relative to when Christmas starts, and that sort of area. I think a lot of data would be useful so that people could take a wise decision. And I don't know if we're doing anything about ending school terms a few days earlier and lateral flow testing our sixth formers at the end of that might be a useful exercise. Thank you.
Yeah, so schools definitely are on our priority list. So in terms of developing a strategy for lateral flow testing, we've been told that it's better to do it as targeted testing rather than mass testing, because mass testing will just mean that it's the worried well and people that we don't want to test that will turn up. Targeted testing will mean that we take it to the right places. So schools are on the list. In terms of bespoke work for sixth formers, I think any work we do with schools, with secondary schools, extends to sixth formers. So I don't think we've done anything till date that separates or segregates sixth formers as a group. But I think that's a good suggestion. In terms of your point around my table and the heat map having different age bands, that's because the table was prepared by BI colleagues within Warwickshire County Council. The heat map was nicked from Public Health England's data, so that's why they're different, Keith. But I take that point about whether we need to think about some bespoke work for sixth formers. I'll take that back.
I think sixth formers are more socially mobile, which is why they travel greater distances and mix in different groups. So I think it's a good one to target. Thank you very much.
Thank you.
Jerry.
Yep, thank you. Good presentation. Thank you very much for that. I suppose just a couple of points really going around back to Christmas. From what I gather, I think all areas of the country have been asked to submit, is it via their regional commissioners, what their views are about exiting, at what tier. And there's a discussion, I believe, going on centrally that everybody will exit onto tier 2 and tier 1 will actually disappear. And there'll be new variances on that. So I don't know whether you had any views around that. And I think, the messaging about Christmas is going to be absolutely crucial. There was one rumour the other day, actually, there'd be an amnesty over Christmas. So, the messaging going forward. So, I mean, if that's going to be the case, there's a definite lockdown number 3 coming, regardless of whatever will happen. But I think there may well be, anyhow, and the quicker we can get that communication messages, the better. And I suppose that goes back to the Health Watch presentation as well, and other stuff I've seen around, is actually making sure that those people who may be deaf or can't see or hard can actually get those messages as well. So we do a lot on social media, but actually pushing those out in a more targeted approach, I think, may be helpful.
Yeah, thank you, Mr. Roadhouse. Discussion around everybody going into tier 2 on lockdown. All I can say is that there's a lot of speculation currently as to what that would look like. What I have been told is that any decision as to how we exit lockdown will not be coming to us until the end of November, so at least a week before lockdown ends. So I'm going to be taking anything I hear now with a pinch of salt. That's not to say that what you've said is not true, but because we've been told from central government that there are also some things that are happening that maybe we will not know until the last week in November. What I do know is that some metrics are being bandied around that will determine what tiers different areas exit into. Hospital capacity is one of them, positivity is one of them, care home positivity is one of them. But it's more or less a waiting game, really. We need to watch this space and see what comes out, really, in terms of statements. Yeah,
I'm sorry. I suppose the point is the Secretary of State will make the decision down at the Department of Health with all that evidence for them. But I'm hearing the same as you, that one of the key factors is hospital capacity and the capacity in the care homes. Thanks.
Okay, thank you. Now I've got one more hand up. That's June, and after that I shall be drawing this item to a close. So June.
Yeah, thank you, Chair. Thank you also for sharing the report with us. Just a point. Myself and my family are already discussing how we can manage Christmas. It's not a nice thing to be doing, so we'll just keep our fingers crossed that we can manage it if we have to and share it if we don't. Just one point, Chair. This is an excellent report with lots of detail in it. And because I am currently here as a substitute on this committee, what I will be doing from the Nuneaton and Bedworth Borough Council, what I will be doing as soon as this meeting is finished is sharing that report with every officer and every member at Nuneaton and Bedworth Borough Council, because I do think it is important that everyone is made aware of the report, that particular report that has come to this meeting. I would hope that those same members will share it alongside of their own, the people that they represent across the borough as well. I think there may be questions asked as a result of my doing that. Sade and I so be prepared for a few questions to be asked, because when people see that, for instance, that there is quite a large rise within the Nuneaton and Bedworth, they won't perhaps understand, as you said, it's about the fact that more testing is taking place. So I think that there are certain things within the report that can cause some questions. So just be prepared. But I do think it's important that report is shared as widely as possible. Thank you, Chair.
Yeah. No problem with that, June, of course. Sade, thank you very much for your report. As members have indicated, it is most welcome, and please pass on to all your staff our thanks for the work that they're doing. We realise the pressures they're under, and we do appreciate, in particular, your time coming to this committee and giving us this update. So thank you very much indeed.
Thank you, Chair. Thank you.
Okay, we're on to item 7 now, the work programme. Do any of our district representatives have anything that they wish to add to the items that they have already submitted? Okay, everybody happy from the districts? Keith?
Thank you. Yeah, it's just one thing from the Nuneaton and Bedworth Council Health Scrutiny. It's unfortunate that the primary care trust item we were supposed to have in October didn't happen due to it falling off the agenda. So that is something that the district is the right place to discuss it probably, but it has dropped off. So it was on the page 68 that we were supposed to have an update on that, and it hasn't happened.
I'll leave that in your capable hands, Keith, to follow up. Okay. At our next meeting, the work programme, we've got the West Midlands Ambulance Service, and we've got the CCG merger, a report on that, and of course we've got our standing item from Sade on COVID. So on the West Midlands, the Ambulance Service and in fact the CCG, if members have got any questions that they would like answered by the representatives coming to speak to us, please do send them in so that we can collate them, get them out to them, and make sure that we get the answers to the issues that you're most concerned about. Are there any other issues on the work programme that members would like to raise? No? Okay, well, that's the end of today's meeting. Thank you all very much for your commitment and contributions. Very much appreciated. I hope John isn't too cranky.
I'm getting more cranky by the minute.
Yeah. And best of luck with Christmas, Joe.
Yeah.
Thank you all very much.
Humbug. Bye, humbug.
Take care. Thank you. Bye.
Bye all. Bye.
Bye.
Bye. Bye-bye.